When Julie's best friend got sick, Julie got a first-hand experience of what it's like to be a caregiver. But instead of just caring for her friend, she built RubyWell, a company turning family caregivers into paid certified home health aides under Medicare. In this episode of the AgeTech podcast, Julie Kennedy, co-founder and CEO, joins me to explain how this works and why it could change caregiving in America. Julie, welcome to the show.
Thanks, Keren. It's so great to meet you and to be here with you today.
Thank you so much for joining. So I would love to start with sort of the origin story of RubyWell. What made you start it, especially since this isn't your first AgeTech startup that you've been involved with?
Yeah. So as you rightly pointed out, I was on the founding team of another company that was originally called Trusty.Care that worked in the Medicare technology space. And that really gave me an opportunity to learn Medicare very deeply. My background really is that I've been an entrepreneur since I graduated from college. I started a nonprofit organization called DC Scores at the time that grew into a national organization called America Scores. It provided after-school programs for inner city youth that combined soccer and creative writing, poetry for children. It's now in 15 cities across the country and still more than 25 years later, still going strong. So I was there till I went to graduate school, and then I shifted my focus to more international work and had the opportunity to work around the world. But in 2016, my best friend was diagnosed with pancreatic cancer. And I had the opportunity, I was really blessed to have the chance to be able to be one of her caregivers and to take care of her and to really join her family and staying with her and helping her through the end of her life. And it was at that time that I joined Trusty. And there was just a lot of thinking of how caregivers manage their lives and survive, particularly in the context of Medicare. So my friend was obviously younger. She was not on Medicare, but I had this opportunity to work in the Medicare space. I became quite familiar with a lot of the voucher programs, the fiscal intermediary programs that operate at a state level under Medicaid for family caregivers, but nothing really existed in the Medicare space. And so I was offered the opportunity by a family office based in New York City to think about building for caregivers. And so I made the decision to go and build what is now RubyWell. And we are focused on leveraging the Medicare home health benefit to support families as they care for a loved one who meets criteria for home health. And then also to empower and engage this workforce of 63 million family caregivers across the country. And for those who are interested, training them and certifying them as Medicare certified home health aides so that they can join the care team and deliver care directly to their loved one in the context of the health system, which would include payment, of course, but also the support of the Medicare home health benefit.
Quick pause here. If you're into AgeTech, make sure to subscribe to the channel. I publish new videos every week to help you stay ahead of the curve. Oh, wow. That is fascinating. And I want to dive deeper into the sort of the training part because becoming a home health aide does require some training. And I assume that it's different in every state. Maybe I'm wrong. How does that actually work?
Yeah. Great. That's a great question. So there's a federal guideline, and 30 states in the US follow the federal guideline. 20 states do not. So in those additional 20 states, what it generally means is that there's not a digital opportunity to learn the didactic component of the training. All of the training needs to be done in person in those other 20 states. And it also tends to exceed the federal guidelines. So the federal guidelines are 59 hours of didactic training, which in those 30 states you can do online, and 16 hours of practical training, hands-on training, which of course you need. You need to learn to help someone get up and down. You need to learn how to turn someone in the bed. You need to learn how to provide CPR, do things that need to be done in person. And so for those 30 states, the 16 hours of in-person training are done either by home health agencies that we partner with in most states, or in the great state of Pennsylvania, where there's grant funding by the Department of Labor, there are also training centers in a couple of different places across the state where those last 16 hours can be completed.
That is amazing that the state provides this type of training.
It's incredible.
Does it cost anything to the family caregiver to get this certification?
Not in Pennsylvania. In other states it does, but not in Pennsylvania.
Got it. And by the end of this training, they're a certified home health aide, and they can basically get paid for what they've already been doing previously for their loved one.
Correct. And they can also, they have a certificate and they have a skill set that they can take to apply in any other professional environment should they want to continue to work in this capacity.
And I know the funding for healthcare in general is to the department, and specifically for people who need home care or home health care. That is challenging. Yeah. What is the eligibility on the Medicare recipient side in order to be eligible?
So in order to be eligible, so the Medicare home health benefit is a benefit that's provided as a core benefit of Medicare, which means that technically it is covered, because it's covered by both Part A and Part B, technically it's covered by original Medicare and Medicare Advantage. What you frequently see is that within the context of Medicare Advantage, the opportunity to receive home health benefits tend to be significantly lower than they are under original Medicare. So the benefit is more curtailed, and the reimbursement rates are lower, which makes it more difficult for home health agencies to serve those patients. And given the US is about 50-50 original Medicare, Medicare Advantage right now, that means there is a large population that may not be receiving care and that needs care. So we generally are focused on an original Medicare population or a Medicare population within the context of Medicare Advantage that pays for the home health benefit either episodically, which is how original Medicare pays, or at a reimbursement rate that our agencies that we partner with are able to accept. So that's on the Medicare, how it's paid side. From the criteria for the patient needs to be homebound. So there's a couple, I think, misunderstandings around the Medicare home health benefit. And one of them is that it exists at all and that it is available on an ongoing basis as long as the patient continues to meet the medical criteria for care. So the law says that Medicare will deliver skilled services in the home supported by dependent services, which would be home health aides, for up to 35 hours a week on an episodic basis. It needs to be revisited every 60 days. But as long as the patient continues to meet criteria, they are able to continue to receive care. That's not how it works in practice. Generally, you don't see people receiving 35 hours of care, and generally, the vast majority of people are discharged relatively quickly from home health. So homebound status is one of the criteria, which means that it doesn't mean you can't leave your home at all. It just means that you need assistance to leave home, or your doctor has told you that you should not leave home. And assistance could mean another person or a cane, or somebody needs to come and get you. But you're allowed to go to church or go to get your hair done, go to the doctor. The other criteria are related to your medical condition. So in order to receive services at home, you need some sort of skilled need. That could be occupational therapy, it could be physical therapy, it could be skilled nursing of some sort, it could be medication management, it could be diet education. There's lots of different ways that skilled need is defined. And then if you have a skilled need, there's an opportunity then for you also to receive home health aid services. And ultimately, the final sort of decision point is really driven by something called an OASIS, which is implemented by a home health agency. It's a very long questionnaire that evaluates your capacity to dress yourself, your capacity to walk, your capacity to go to the bathroom, to stand alone. It evaluates your fall risk. It evaluates your hospitalization risk. And the intention of home health is to keep you and treat you at home rather than to be engaging much more expensive services such as hospitalization, which is what we're trying to prevent. So that is how to think about the home health benefit. There's so much more to go into. It's maybe a little bit too technical, but it's a very, very important benefit that is highly underutilized in the US.
It's sad to hear that it's underutilized, and I assume it's because of what you just mentioned, that so many people don't even know that they are eligible for it.
Yeah.
I wonder,
Yeah.
what does that actually mean for Ruby? Did you have to become a national home health agency?
No. So we're not. We're a technology provider. It's a great question. So if you think about Medicaid models like a Abbey Health or Italy, they operate as agencies in individual states because Medicaid is administered at the state level. Medicare is a federal benefit. So we can partner with home health agencies across the country. We deliver the technology and we partner with families. We identify and partner with families to allow them to have care delivered. So we operate in 4 states right now. We could be operating in more, but we're not limited. We're limited at the state level by the training regulations and by any rules that govern the home health agencies from an audit perspective. But we work fully within the rules of Medicare. We're not tacking on anything. We're just sort of rethinking the existing benefit under existing regulation. So we are not incorporated as a home health agency.
And the benefit for home health agencies to partner with you is that they get basically more clients and more caregivers to come with them. So they don't need to staff this.
Yeah. I mean, they need to staff it with the skilled services. So although we do have family members who are LPNs and RNs who join RubyWell. And so they obviously are coming with a much higher skill set to these agencies. But so the benefit for the agency is that we are identifying people in the community not being discharged from a hospital or skilled nursing facility who meet criteria for home health and don't know that they are eligible. And so this is a population that's not receiving care. It's generally a complex chronic population, which means they're an expensive population to care for. And so treating them in the home is the least expensive way to treat them, particularly if there's a family member who's anchoring care in the home. And so what we are doing is we're identifying patients that the agencies would not normally identify through their intake channels. And we are also providing them with greater support in the home so that we're looking at not just a workforce, but in a value-based care system, we're looking at improved outcomes from a cost perspective and from a health outcome perspective.
And if I understand correctly, Medicare pays a certain rate for home health. So it's not just like the agency can charge whatever they want, like they do with private pay.
Yeah, no, you're right.
So not all agencies even work with Medicare because it's not necessarily profitable. Correct. So how did you select the states in which you want to operate in?
So every state has a relatively high number of Medicare certified home health agencies because at the end of the day, there are 4 million Americans who received home health benefits last year. And so there are about 12 million people who need them, but it's a pretty big business. And so we are able to identify agencies. We are certainly looking for agency partners that have high star ratings and are delivering high quality care. And the reason for that is because we're very interested in the outcomes. And if you are dealing with an agency that is not delivering high quality outcomes, then we're not necessarily aligned in our purpose. But we chose the states that we operate in a couple ways. One is because they're states, we're in Arizona, Florida, Pennsylvania, and moving into Massachusetts. And certainly Arizona and Florida are very high, are states that have a high number of older adults. And they also are states that have a high number of older adults on original Medicare. And so those were drivers. And then in addition to that, there's states that have very good home health agencies. Florida is a unique state in lots of different ways, but there are high quality agencies that operate there. And then Pennsylvania is a really interesting state because it's very working class, very heavily Medicare Advantage, probably 70-30, which is not the mix that you see at the country level. But the state of Pennsylvania has also, the Department of Labor and the Pennsylvania Home Health Association has really sort of taken on this initiative to train a workforce. And so there's lots of other types of opportunities. There's also some very big healthcare players like UPMC in Pennsylvania that provide some opportunities for managed Medicare to be operating effectively within the home health space.
Wonderful.
So yeah.
What's been some of the milestones that Ruby Well has achieved so far? And what like advice would you have loved to give Julia a few years ago to maybe reach these milestones? I know if faster, but maybe with better well-being, because I know being a startup founder is hard.
It is very hard. Yeah. Better well-being. I'll have to think about that one. So from a milestone perspective, I think when we started this, nobody believed that Medicare would pay claims that had home health aides that were being staffed by family members, right? It was like this concept, but it didn't exist in practice. And so I think that there is, there's, from a very technical perspective, there are challenges to what we're doing. And one of them is that home health aides are used less now than they were prior to. There's a new billing construct called PDGM, patient-driven grouping model, that came in under Trump 1, and it really has changed how home health staffs care. And so there's been a reduction in the use of home health aides, and there's also been a reduction in overall hours delivered through home health. And so we're dealing with a complex chronic patient population that needs more care, not less care, and treating them at home. We just completed a study with Wakely Actuarial that I'd be happy to share with you. Patients who receive home health services cost the federal government, cost Medicare $3,600 per member per month less than patients with the same diagnosis who fit the same profile who don't receive home health. So the numbers are staggering. So for this population, complex chronic patients, we want to be treating them at home. And so I think one of the greatest breakthroughs that we've had has been getting these family members through, 70 odd hours of training, getting them certified by the state of Arizona, by the state of Pennsylvania, having them working with the home health agencies, and having those claims paid by Medicare. So we are operating fully compliantly within the law. These people are fully certified home health aides. They are under supervision of a care plan of a skilled nurse, and they're a member now of their family's care team delivering care. And so I think for us, that was a really exciting breakthrough to show that you could do it to start with, right?
Yeah.
And I think now we're moving into managed Medicare in a value-based care environment, because the other thing that we've been able to show with our research, and then also thanks to other great partners out there who are doing great research like Duke, Home Health, and Hospice Association, we are able to see on a value-based care and on an outcomes-driven basis that not only care at home, but care at home with anchored support by a family member delivers dramatically lower total cost of care, significantly improved outcomes, significantly lower hospitalizations, institutional use, all the things that we want to be doing, and essentially in what one could call a consumer-driven healthcare environment. This is the consumer making choices about where they want to receive their care and being cared for by the people that they want to be cared for by. And so I think we're really excited about that opportunity now as well. And I think I don't know that I could have effectively told myself to like work less and vacation more if we start like days. More yoga, maybe. I still need more yoga and I still need more meditation. But I think that we really went all in on original Medicare, and I wish that we had understood the opportunity in the value-based care environment a little bit earlier, but we're on it now. But I think that that blend, because original Medicare doesn't really operate in a value-based care. I mean, if you're an ACO, you're operating in a value-based care environment, but a lot of original Medicare doesn't. And really understanding the drivers of total cost of care and the drivers of outcomes in the context of these family members is really exciting. And from a data perspective. And so, I would have liked to have looked at that in both environments a little bit earlier.
Absolutely. So in order to basically start the company and grow and scale, you have to find people who are eligible to receive the home health benefit, and also that they have family caregivers who are able and willing to go through the training and provide them with the care. How do you find these people?
Yes, one correction I want to make is that it doesn't have to be a family member. It could be a friend, it could be a neighbor, it can be anybody, right? It doesn't have to be a family member. And I think that's actually a really important point because not everybody has a family member to take care of them. And so I think when we think about the population that's providing care right now, while we use the phrase family caregiver, it's important to remember that sometimes it's the neighbor down the street. Sometimes it's, a friend. And so we have done, I think, quite a good job of developing very rich education and content for families. We're very focused on the financial journey of family caregivers. It's very, very burdensome and difficult to care for somebody who needs significant care in an environment where there's limited long-term care support in the US. And I think from a healthcare perspective, there's limited opportunities. If you want to access those services, you need to spend down to Medicaid. If the entire population spent down to Medicaid, to be able to access Medicaid, you'd bankrupt the system. I mean, only 3% of the population receive long-term care benefits currently. So we need to find different pathways. And we started by communicating and educating families about both the home health benefit and about the opportunity from a work perspective to think about how to provide care in a structured environment where as a family caregiver or as a friend or neighbor, you are also receiving medical, clinical support from the rest of the care team. So you're not in it alone. And it took us a while, I think, to get the messaging right. I think people still conflate what we're doing with the Medicaid benefit and don't actually understand when we talk about what we're doing that we're talking about Medicare and not Medicaid. And so it took also a long time. We got a lot of families on Medicaid who were seeking, the voucher program or whatever the benefit was in their state. And so we have worked with other agencies who serve that population to hand off those families, which in and of itself has complications associated with it. But we, I think now have really, and we can tell basically by the cost of our marketing and the volume of people coming through our funnel, we're starting to hit our sweet spot where we're identifying the right population and we're communicating clearly about the opportunity and the benefit. And we have found we've moved far beyond, digital channels. We market through lots of different channels. And we're starting to find that marketing mix. It's helping us identify this population. The majority of the patients who meet criteria for home health and who are being cared for by a loved one are cared. So there is are cared for by someone very heavily sandwich generation, sort of in their 50s, or in many cases, spouses who are older. And it is generally a population that is over the age of 70, unless they have a early onset disease. And so a lot of it has been understanding where this population lives and who they are and how to find them. And then the other component of this is there's probably about 30% of the population that's being cared for by a young person, like a really young person. And so the other element of this has been for us to understand how to find college students, high school students who are providing care for a grandparent or a parent and who may feel really isolated. And that's an entirely different outreach strategy. And we frequently find them through their parents rather than through them directly. But I think we're starting to develop our marketing and our outreach a little bit more effectively for a younger population.
It sounds very, very challenging to sort of find not just one ideal user persona, but two, that they have them coming as a pair.
Yeah.
So I guess it makes
It's
a lot
not,
of sense.
yeah. It's not simple. You know, we don't pretend it's simple, but I also think that there are, you know, about 12 million people who fit this, who meet criteria, and there's 63 million family caregivers out there. This is a complex chronic population that we need to treat at home. And so I think that this is, again, if we're dealing only with the original Medicare population, we're missing half the population by not operating in a managed Medicare environment. And this is why we're moving into this much more outcomes based environment, because we have this data now that shows the effectiveness of this care delivery. And at the end of the day, I think we're operating in an environment where the population is aging rapidly, is sick. And if we are not able to care for this population at home, and if we're not able to care for them in a way that reduces overall cost while making people feel better and feel happier to stay home, this system's going to collapse in the next 10 years, right? It's not like we're making improvements systemically to address these problems for aging adults.
For sure.
So I think we're very excited about the care delivery opportunity in the home.
I'm excited about it as well. I saw online when I was preparing for this conversation that you had raised some funding about a year ago, or at least it was announced a year ago. And everything we just talked about, and I'm sure that everything that we didn't talk about, is incredibly, incredibly complex. And I don't believe I've met any American who truly understands the American healthcare system. And certainly when you become, when you get on Medicare or when you become a family caregiver, you're often not really, you don't really have the bandwidth to learn everything that it is to learn. What was it like to go and fundraise and to have to basically, I assume, educate everyone on every pitch on what exactly it is that you're solving and why it's even a problem?
I mean, it was crazy. It was crazy. So I think there's a couple things that really worked in our favor. One is that the pre-seed round was funded by the family office that I mentioned. And I think that the mindset of the family office was more patient capital and trying to unlock a really difficult problem and a really huge opportunity. And I think that that kind of early stage funding can allow you to dig into some of these darker corners of the American healthcare system than maybe if we had, some of it is, you know, we could have bootstrapped, but if we tried to raise a pre-seed round. So by the time we were raising a seed round, we did have a team and we did have some evidence of what we were doing. And so regardless, the fundraising was just crazy. Like I would talk to people and in 10 minutes, I would know they would have absolutely no idea what I was talking about. And as a CEO and as an entrepreneur with limited time and limited energy, like how many calls do you want to have with people who don't know what you're talking about? And yet the other thing that's really interesting when you're raising is you get tons of inbound from people who are just shopping, right? They just want to talk to you. They just want to know what you're doing. There's a lot of FOMO. And yet on the one hand, there's the FOMO. And on the other hand, there's the fear of being the first mover and being, okay, yes, I'm going to take this plunge. And so I think we're very lucky in the investors that we have. The round was led by Primetime Partners, and Primetime absolutely understands the age tech space and fundamentally understood what we were trying to do. The family enterprise, Loeb Enterprises, obviously had been very supportive and continues to support the company. And then we brought in a couple large investors and some smaller investors who anchored the round and who are not necessarily health tech investors like a town hall is, but who really understood the vision of what we were trying to do. And so I think we're very fortunate. We closed a $4.2 million round at the end of last year. And so we've still got some runway to go before I have to raise again, which I'm thankful for. And we have a great board that I think has been really supportive. And one of the, I think, exciting things about our board that helps to your point about understanding the healthcare system is we recently added a VP from Kaiser to our board who is in the care continuum and technology space. And her addition to the board with her deep, deep knowledge of healthcare, of caregiving, of home health, older adults has really, I think, enriched our board's ability to provide strategic advice.
That is wonderful. Do you have any advice for startup founders who might be watching or listening who are just getting ready to raise their seed funding?
I mean, it's such a tough environment right now. I mean, so this is kind of a weird thing to say because on the one hand, I think everybody says it, but one of the things that we have been doing much more is really leveraging just existing off the shelf AI tools to both make our product more efficient and to make our operations more efficient. And it is kind of amazing how much productivity you can get by sort of leaning in. I think as we are developing sort of this next phase of our products, we're leaning into that significantly more. They're very having that capacity, the sort of powering your product, I think does make a really big difference. And for better or for worse, it's what fundraisers are looking for. I mean, funders are looking for right now. I think if you don't have intelligent processes built into your products, it's going to be very difficult to raise. And it's difficult because every sort of 2.5 years, there's some new thing that's coming along, the catchphrases, whatever it is that you need to lean into in order to raise a round. But at the end of the day, if you have a great idea that you believe in and you're able to demonstrate that you can execute against, I think that the founder's vision, the founder's passion, and demonstrated ability to execute is ultimately what will help you raise your round. But I think the other really important thing is to make sure that you are bringing on investors that you believe in and that you want to partner with, because they're going to be sitting on your board and they're going to be part of your life every day. And you really want to be sure that you're aligned in what you're trying to do. And healthcare is hard and slow. This is not, the next, I don't know, deep tech, LLM, that everyone is going to, you jump in and fund. And if you're trying to make systemic change, it takes time. And you need investors who are going to be on that pathway with you and help you do it as efficiently as possible.
So tell me a little bit about your tech stack. How does RubyWell actually work?
So we have developed a really exciting data model that after we've identified this population, meaning they come to us and they say, I think we meet criteria for home health, we are able to gather a bunch of different information from them that allows us to predict whether they meet criteria for home health and then how long they're likely to stay on home health. So when someone comes in, we can evaluate their homebound status, we gather claims data, we can look at EHR data, and we can actually, by intaking this information, evaluate the status of the patient and predict what care should look like for them. And so this is ultimately why the home health agencies, we partner with home health agencies, because it's also helping them have a better understanding. This is true for plans as well, by the way, a better understanding of an individual patient profile and the care that they need and how that care can be delivered. And within the context of the home health benefit, if somebody meets criteria and we can see that that could be preventative in terms of future hospitalizations, future more expensive episodes, it's a great opportunity for intervention. So our technology has really been built around ingesting individual household level data and predicting what can be done for that particular person for both their opportunity to access home health, and then once they receive home health, what that relationship with home health could look like over time. Because home health in many cases can also just be the starting point. It could be a bridge into palliative care. For many people, it could be a bridge into hospice. So there's an opportunity here for a complex patient, instead of them dropping out of care and then showing up in an emergency room or showing up with a severe hospitalization and then being discharged into a skilled nursing facility, there's an opportunity to prevent all that spend up front by understanding the profile and the trajectory of the patient's illness. And so I think it's been exciting for us to be able to build these data models that are predictive. And then for our home health agencies, that we have also built a portal for them, essentially, where they're able to access patient data, everything. We're SOC 2 Type 2 certified, so everything is within a secure environment, and we're able to exchange information about patients, communicate about patients, and make sure that the patients are onboarded and are able to access the care that they need.
That is amazing. And do you get requests from agencies to analyze existing customers or even prospects? Like, I have 3 prospects and I only have 1 available caregiver. Which one should I get on board?
So great question. We have had requests to sort of review an entire census. And so we're a relatively early stage business. We're a seed stage. And so we are really talking about the algorithm will need to be in the it's not just the algorithm, but the way that the engine ingests and learns the data will need to be a little bit different when you're taking census data from a home health agency versus taking information from a family or an individual. So, as you probably know, to access claims data, you need permission. Claims data has been a really important input into our evaluation process. And the data that we would receive from a home health agency is in many cases limited to the episodes that they've had with that home health agency. So some of the things that we're trying to figure out is how can we enrich that data in order for us to do a really good job predicting based on existing census with limited EHR data, let's say. And so I think that that is a future horizon for us. That's something that we're really interested in. The other request that we've had from home health agencies is actually to manage all of their intake. So any patient that comes referred in from any place would go through our engine. And so I think these are different pathways that we're exploring. And as we think about training our model, thinking about what the data would need to be able to look at those 2 additional use cases.
Well, it sounds like you have multiple growth opportunities for after you reach the 12 million Americans who are eligible for home health benefits.
You know, I am a really big believer in the home health benefit. And I think we're in a very difficult government moment in the United States where healthcare benefits are being cut, where support for the average person is diminishing. And I think that it is incredibly important for all of us in the age tech space as entrepreneurs to advocate for and to support not only the work that we're doing, but if you work in healthcare, policy really matters. And so to really advocate for policies that are going to strengthen the infrastructure of the United States in terms of care delivery. And so I think that that is something that I'm really excited about. I spent all last week at 3 different conferences, and the healthcare community is very tightly I think it feels very cohesive and in a very difficult moment, very positive and pushing for change. I think in these moments of great difficulty, there are great opportunities for change. And I think from an entrepreneur, that's really exciting. If things are going great, it can be a lot harder to innovate. But I do think understanding the moment that we're in, both from a policy perspective and an innovation perspective, is really, really important for people who are thinking about innovating in healthcare. And I'm also just remain super bullish on family caregivers, right? There's such a huge opportunity to leverage this workforce that is invisible and that is providing billions of dollars of care at home. And we're at the precipice of really seeing care delivery move into the home in a meaningful way. And it's simply not going to happen without this workforce and sort of taking these 63 million people that are faceless and moving them into a more formal, identified environment. And I think that we could see real transformation in terms of care delivery by leaning into this opportunity with family caregivers. And for Medicare to lean into that, not just Medicaid. So I think there's a really big opportunity here.
Absolutely. And there's so much opportunity to support family caregivers. Yeah. And I see more and more startups doing that. So I'm really excited about what's to come. Is there anything that we didn't talk about that you would like to add? Any call to action to the audience?
Get engaged with healthcare. Now's the time. It's the, biggest spend in the United States. It's the most important issue. All of us at one point will need the system, the healthcare system, to be there for us. And all of us one day will either be a caregiver or need a caregiver. So absolutely, now's the time to embrace this component of our economy.
Absolutely. I think that is a call to action everyone can get behind.
Right.
Julie, thank you so much for joining me on the show today. It was an absolute pleasure chatting with you and learning more about home health through Medicaid. Thank you so much.
Thanks, Keren. Great to meet you. Take care.
Thank you. If you enjoyed this conversation, there's another video of YouTube things you'll enjoy right here. Until next time, stay humble, stay curious,